I always wait too long. I always wait too long before I start talking. It's like there's this awkward gap where I'm waiting for something to happen, right?
But this is good because I always wait till you talk before I say anything.
So I've just learned I'm just gonna start talking in the middle of the audio, or in the middle of the intro, and then all bases are covered here. Hey everybody, welcome back to the Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni here with me to my left. I got Ray Pace to my right, and our show notes and our show description is lying to you. We we are missing a Dr. Spanner, and in lieu of, we will ask to sub in a Dr. John Hill. Oh, look at that! Right on cue. Almost nailed it. He nailed it. Dr. Spanner could not be here today, maybe because somebody forgot to put the invite on his calendar, or maybe because he forgot. Let's say it's probably one of those two things. One of two things, right? Or, it's a combination of the two. But regardless, we still wanted to run this today and not do it on a different day. So. Hey, John, you happen to know anything about shock? Because that is our topic, and we're going to continue on. Sadly, you're going to get the questions I had teed up for Dr. Spanner, but
hopefully I can do as good as he would have.
No, he had. And again, if you guys have not watched the first 3 parts of this,
it was a good episode.
It was actually a very good episode. The show notes that nobody helped with, they're even better. So if you're not, you ask 4 days later. If you're not checking us out at prehospitalparadigm.com, not only do we have the show notes, we've got the audio product, video product, bunch of other notes and other links and whatnot regarding the show. There's more than just this live, and yeah, we want to refer you back to the bulk of the content that was in that in the first 3 parts earlier in the month, because again, there was a lot of information, and I think that we did a decent job of getting that distilled down into actionable
into
tools.
EMT words.
Yeah.
So we're not talking about 300, 360 joules, all that. That's not that kind of shock.
No, not that kind of shock. Even though, did you see on the web page, I have a couple of wires arcing across. It's shock, right? So, having said that, I wanted to get into. One of the things that is in protocol that is going away, talking about shock. One of the things that's in protocol but going away, and much to my chagrin, are the rescue guards.
Yeah.
So, for those of you that, do we have one here? I knew I was going to talk about it. I should have had one. Oh, here's one. The rescue guards impedance threshold device. You probably have this on your ambulance and have forgotten about it, and that makes me sad, because this is a very utilitarian device specifically for our EMT providers, and it's going away not because we don't like it, not because it doesn't work. Frankly, I was excited to have it for my BLS providers historically, because it was the only thing they had to raise blood pressure, and to do that with essentially nothing that required any big intervention, right? They just have the patient breathe through this. It creates a negative interthoracic pressure. It makes a little resistance to inspiration. Negative pressure in the chest draws blood back into the chest.
Yep, increasing preload, increasing afterload, getting you better blood pressure, typically between what we had talked about, 10 and 20 points, 10 and 15 points, ballpark. In my experience with my crews, around 20 points of free blood pressure, right? Without
that's between needing push-dose epi and not needing push-dose epi.
And sadly, this is it's still going to be in protocol for at least the remainder of 23 and into 24, because we haven't taken it out in 24 yet. but the manufacturer has discontinued these, so we can no longer get these. So if you have these on your truck, once you use them, there's not going to be a pool to replace them out of, which makes me kind of sad, because again, we had a tool here that was perfect for the EMT.
Or for the paramedic, just to buy you some time. Like, hey, I'm going to put this on you now until I can get an IV, and if I need to, give you a fluid bolus or move to the epinephrine push dose presser, it was just a non-invasive way to gain some systolic,
This was perfect for the hemorrhagic shock patient because you're buying blood pressure without hemodilution, right?
Yep. Yeah.
We're not pouring crystalloids into them, making Kool-Aid. We were talking about making Kool-Aid the other night.
Dilution. Is not the same.
Making blood Kool-Aid, not like Kool-Aid to be followed, right?
When the phlebotomist draws the blood and it looks like water, there's a problem.
Yeah, right.
So it happened to me over Thanksgiving.
That was literally so.
I had two shock patients.
I guess
over Thanksgiving.
Let's talk. I guess that kind of opens the doorway to some pitfalls, right? Of overhydrating, of overuse of our crystalloids. Once you give a synopsis of what happens when we are not judicious with our fluid resuscitation, and
so the easiest way I can make this is something I learned in the 6th grade, and I didn't believe it then, but it stuck with me since. And the saying was, we were learning about pollution in the ecosystem. And the solution to pollution is dilution. So that's what's happening in the blood. You're going to dilute you're diluting out all the good stuff you want there, all the clotting factors, all the platelets, all that. You're just diluting it down with water.
Yeah.
So if you have a few liters in your circulating bloodstream, all of us probably have about 6 to 7 liters. If I give 2 liters, I've now diluted that down quite a significant
by a
amount.
quarter, yeah.
And it's to that point, when we talk about trauma resuscitation and hemorrhagic bleeding and hypotension, the American College of Surgeons that do our trauma certifications want us to hold at essentially 1 liter of crystalloid solution. Yeah. If I'm still hypotensive after a liter of solution, I should switch to blood products.
Right.
Yeah.
Now, that's obviously not possible for you in the field if you don't have blood products. If you happen to be a flight medic or flight nurse and you're on an aircraft and you have blood products readily available, yeah, you're going to go to that. But no squads can start blood in the field. So you only have crystalloid solution. So for those hemorrhagic shock patients, and all shock patients, let me rephrase that, all shock patients should have at least 2 large bore IVs in bilateral ACs or large vessels, so we can do volume resuscitation. If that's all you got, that's all you got, right?
Right.
You should be able to flow in a lot of crystalloid or fluid or whatever you have there in a very short amount of time with large bore IVs, pressure bags. You're not having a micro J-loop set, right? Whatever. And even in Spanner talked about this. You guys talked about this during the actual recording, and we talked about it in residency. We put in central lines. Well, I can push a lot more fluid through an 18 gauge, even a 16 gauge line than I can even a central catheter. And then we talked about introducers, which are literally garden hoses.
Sure.
I can slam in 1 liter of whatever in a few minutes.
Right. Yeah. Well, one of the things we talked about in the resuscitation component of that, I was, of course, harping on choices in the tubing and extension sets and stuff. You were harping
angiocath sizes,
and you were on angiocath sizes, and you were talking about squeezing stuff in. But even an IO, a humeral head, 6 to 8 liters. Or 4 to 6 liters, an hour in a humeral head. Sometimes that just kind of goes over your head and you don't think about that. That's a
significant amount of fluid.
That's still a liter in 15 minutes or a liter in 10 minutes, depending on how hard you're squeezing it, right? Do some people, do you occasionally have a 4 or 5 minute ride to the hospital? Yeah, but you also have at least that in scene time, right? So the one thing is John and I were in conversation a couple of days ago. It's with a couple of large bore IVs, being aggressive with pressure infuser, be aggressive with the size, or multiple IOs, right? if you try harder, you can get a
it,
fair amount of fluid in, because Dr. Spanner was absolutely correct. You start an IV, you drip it in, yeah, you get a couple hundred in by the time, even in a moderate transport time, you only got a couple hundred in by the time you get to the hospital. But you can amp that up if you really auger in
And you really should. If they're truly sick, if they're truly hypotensive, that's all you got.
Yep.
Slam in your fluids, right? If I'm the basic on and Ray starts the IV, Ray hands me the bag and says squeeze. I go okay, and I just keep squeezing as he's mixing up the push dose pressure. Because by the time I can squeeze in, let's say I get a 500 cc bolus, and if that blood pressure's not doing anything, we talked about this again. Just go ahead and jump to that epinephrine.
And there's got to be something in the container for it to squeeze too. So if you can get the head start on that, and give the pressure, then you have that fluid.
Boy, it's almost like I told you what I wanted to talk about. So the other thing is we often spend so much time on the initial thing, right? Is choosing the right thing to begin with. So with our distributive shocks, of course, some fluid and then a pressor, right?
Yep.
And I feel like in all the other shocks, it's like we push volume resuscitation and we don't talk about the failover. So I want to talk, this is my note, right? It's lose-lose situations, right? So there are those patients that are just in such profound shock that it's literally lose-lose, but you have to do something. You have to do something, right? And although vasoactive medications like push-dose epi aren't necessarily indicated first line in hemorrhagic shock.
Correct.
Right? They need volume. They need blood, right?
Yep.
And oh, by the way, that is still a large portion of what you do as EMS is finding them blood, right? Whether that is an aircraft, whether that is appropriate triage, driving around the dock in the box, taking them to a place that you know has a blood bank. That's still part of your decision making, even though you're not administering it, right? And then lastly, if that fails in your time, it's not disallowed to then transition to pressors. Should it be no, you should in a hemorrhagic shock case, you should fill the tank up first and then start squeezing the container down around the volume. There were 2 cases as of recent. Again, he and I were talking about this the other day. One with our flight crew. They were bringing a GI bleed in from St. John West Shore, and the patient had already received fluid resuscitation as well as blood at the hospital. And then in flight, the patient again crapped out their pressure. They're squeezing more blood in this guy, and his pressure is still awful, right? So they were using a vasoactive medication. They use phenylephrine. They don't use push-dose epi, to clamp that down to get the guy's blood pressure up. But again, that was done after appropriate volume resuscitation. There was another case, our specialty care service was, it must have been GI bleed week.
Yeah, right.
But it was basically the same story. Patient had gotten blood and fluid at the hospitals. Blood pressure got soft. They got an additional volume resuscitation during transport, and then they switched. They don't have phenylephrine. They used push-dose epi. And that little bit kept that container tight around that volume, and they delivered that patient with a solid blood pressure, right? So it's not an absolute no. And if you're not sure, again, it's the subtext of this entire protocol. You can always call med control, right?
But I think we have to remember too, we're not trying to make the pressure. I mean, normal would be awesome.
Yep.
But we're just trying to make it better.
I think
and
that's
we can
huge.
deliver a patient who's perfusing to the physicians who can then make it normal. So if that's through surgery, it's through surgery.
In shock, we want permissive hypotension.
Yeah.
Just like in strokes, we want permissive hypertension. The body is really smart; it knows what it needs. If we can just get a little bit of push-dose epi and we have systolic blood pressure, ideally over 90, but really it's more about MAPs. If your MAP is 65, which really it's over 60, we just want that buffer.
Yep.
If
Padded.
it's 65, we're happy. I don't need any pressors. If we're running steady at 65, that's great. I had 2 septic shock patients over the weekend. One of them, they're both sign-outs to me. And so I took over their care. Guy had really bad pneumonia. Ended up putting him on BiPAP. So BiPAP increases intrathoracic pressure, decreases venous return. We dropped his blood pressure. He needed a little bit of pressors. A little bit of pressors just to get him up. He was actually maintaining fine. His blood pressure sucked. I think he was systolically 88. But his maps were okay. As soon as we added on that positive pressure, it decreases intrathoracic return, drops his blood pressure, needs a little whiff of pressors. We use Levofed preferentially in the emergency department in the hospital setting, but we don't have Levofed in the field. We've chosen epinephrine in the field because it's already in the box.
Right.
I don't have to give you one more drug. It's one less drug I have to manage in the field.
And it's such a quick response, too.
It is.
And then on the flip coin, it's also such a quick out if I need it to be. So,
Yes.
So, I mean, I appreciate it that it's there. I think it's an awesome presser to have. I think dopamine was, I don't know why it was so confusing to everybody, but it was a little more math to it.
Yeah.
It worked.
Well, I mean, you could
It's
make
not the best choice, though, either.
You could make the same argument for an epi drip, right? What's going to turn people off from doing an epi drip?
It's a drip.
It's math.
It's math.
Come on, it's math, right?
Oh, I know.
Titrate to effect.
Yeah, but again, I think we do a little bit of disservice in, at least we historically did. I know certainly you and I strive to break some of these illusions of how some of these, like, you read the back of the textbook, or you read something about epinephrine, you are going to throw every single patient into a uncontrolled tachyarrhythmia. Or you read about dopamine, right? It's going to have these profound and it's all this very black and white stuff that it's hard to operationalize once you get into the field, right? So you have these, like, let's take low hanging fruit here, albuterol, right? If you read the back of the book, right, for like it's like, I am going to make every single patient tachyarrhythmic, and it simply does not happen, right? And
Can it happen? Sure. There's some effect there.
But going back to that dopamine thing, I think most of that was the way it was presented to us, and then subsequently it was hard. You had to remember math.
It wasn't easy, and then I think people are just more comfortable with a push. I mean, look at TXA.
That's what we do.
TXA has given you the option to move to a push. Epi, pressor. Now, both of those drugs are prime examples to deal with. Let's talk about, since we're talking about shock, it fits. You can either drip them in, or you can use them as a push dose. And it just seems like we have gravitated more towards push dose and comfortability of that. But I think it's the whole picture, and I want to jump back a couple segments if I could,
Sure,
and then I'll jump forward, is it's not just black and white, and I think that's what people need to remember. Your BLS skills come in. So if it is a hemorrhagic shock and I can see the bleeding, then you need to stop the bleeding first. It's all the components that you talked about, from I'm going to establish a large bore IV, or I'm going to move to, let's say, a humeral head IO, and then my drip set piggyback into that. There's a lot of providers, because we're back to a drip again, even though it's saline, they get caught up on, well, it doesn't matter if I use a 10 or a 15 or a 20. Yes, it does. So you want a 10. I mean, our ambulances in my organization, all we carry is 10 drops.
Yeah.
There's a 60 in a ped bag. That's the only reason it's there. It's in a pediatric bag. That's it. You can't readily grab a 60 drop out of any shelf or anything. They're all 10s, because we've designed the protocol for that, for burn protocols, for trauma protocols, for the epi drip, the TXA drip. It's almost like it was meant to be that way, to make it very easy. So I think you got to look at the whole piece of the pie. You give that volume replacement, and then you might have to partner it with that. So if I've filled the tank as much as my limitations allow, because I don't want to affect their clotting factors, I do not want to decrease how much hemoglobin's in their blood, because if I just pour more fluid into them, they're just going to bleed more. They're also not going to oxygenate, and you might have to pair it with a pressor. So it's not just one tree. A lot of people look at that protocol like box A, B, C, D, and that's not just it. And it's a combination of all of these things coming into effect. And just like John's patient, you put him on CPAP, and you increase their intrathoracic pressure. I'm going to decrease my cardiac input and output, my preload, my afterload, so my blood pressure drops a little bit, but it's okay. We can adjust to those things.
You can manage it,
And I think something you said too, John, to your point, that it talks about Well, I want to make their blood pressure normal, right? So that MAP of 65 in our world is normal, because if you continue to push and give, let's just say, normal saline, and you increase their blood pressure, what do you think you're doing to their hemorrhagic shock? You're making it worse. If I increase their blood pressure, I'm going to make them bleed more. I don't want that. It's just all of those factors. Sorry, my little rant tidbit there.
No, that's good.
Perfect.
And I think that set him up for a story that I asked him to tell. Yeah.
So Dr. Spanner had war stories. I just have residency stories.
Which,
Yeah.
okay, yeah.
Same, but different.
Yes.
But not the same.
So to that point, I had a woman during my residency. I worked really hard to keep her alive in the emergency room. We admitted her to the ICU. She had a large uterine mass or ovarian mass, something cancer in her pelvis that was bleeding like stink. Non-operative, but we kept her alive. The overnight team in the ICU drove her blood pressure up to normal, and then she coded in the morning because she started bleeding all over the place. We couldn't control the bleeding because blood pressure came up too high.
Pop the clot.
The clot. We couldn't reestablish the clot, and she died on us. Yeah. So again, permissive hypotension is okay. MAP is 65. That's the goal. Bring them to us. We will manage it from there. And all the time, patients are hypotensive in the operating room. They're hypotensive in the ICU. They're sick patients.
Yeah.
It's okay for them to be hypotensive. We can manage that hypotension.
Right.
Yeah, and I think we've increased our education on drips over the years substantially. I mean, when did we start with an epi drip in our protocol? 3 years ago?
Yeah, 4 or 5, yeah.
And I mean, I think as I can speak for our organization that we're all part of, I think when we do our CE, we really got to a good point where it's like, hey, here's the formula, here's the drip set. This is what you're looking for, and the comfortability has gotten better.
Right.
Everybody is more comfortable to do that. It's just easier to do the push dose epi, or it's easier to do TXA as a push versus a drip. But I think we've taught it a lot more than versus in the past where it was like, this is dopamine, you'll never use it, but it's here.
This is the lidocaine clock.
Right, and well, I mean, those exact words have been said, right? And that is, that was a shortcoming of education, and that was certainly shorting the patient. We could have an entire segment on epi versus dopamine and
versus Levophed versus
we could
phenylephrine
that
versus vasopressin.
Correct.
Yeah.
That could be a discussion in and of itself, but. It was the vasoactive drug we had at the time to fulfill that
100%.
space. Does it make intuitive sense to me today to say, why was I trying to synthesize epinephrine into something different when I just had epi the whole time, right? That makes logical sense to me today.
Yeah.
But it was what I was, it's what I was handed, right? Mm-hmm. And it's kind of
and with science getting better, studies, AHA 2020 updates talked about the difference between epinephrine versus dopamine as a pressor. I mean, it's just as time continues to evolve and science continues to evolve, we'll definitely change our treatments to be more aggressive and have more data on a lot of those things that we didn't used to.
All right. Well, I mean, the funny part is what do we go back to? We're going back to agents that the body naturally produces to keep itself alive, right?
The body knows what to do.
It knows what the hell to do. Wow,
point.
that's amazing,
The
right?
body trying to fix itself.
We're literally even your levo, right, is norepinephrine.
Yep.
Yeah.
It is the other sympathetic mediator of the human body, right?
Crazy, isn't
The body knows, and we're just augmenting with what the body already knows, right? The in that whole vasoactive space, but.
I think a little more important. I mean, it's awesome to talk about the medications and the pressors and all that, but we have to go back to basics too. That you need a really good history and physical assessment for any of these patients whom are hypotensive, probably because of trauma or a bleed or something. And there's signs and symptoms out there that lead us to our field diagnosis, and hopefully we're coming to those and coming to you with those and getting them to the right place. Because if they're not getting to the right place, I mean, can Giaga handle a AAA all at once, So I need to be getting these patients triaged very well and look for things like Gray Turner sign or Collins sign or what's the pressure or what, so taking it back another step just for a second and saying that, you really have to, IVs are great, but basics can't do IVs. Pressors are great, but basics can't do that. So going just back to where does this patient need to go? And I personally hate the golden hour of trauma. I feel like it was a sales pitch in the day, but it still makes sense. We still need to get these patients to a trauma center where they really need to be. And if I miss that and my field diagnosis as a patient provider and I take them somewhere they don't need to be, I've just killed that link of the chain. So,
well, and I think to your point too is like to talk about the hour that we have, I think some of the basic things that can be done that we can correct on the scene is decreasing your scene time. So if
under
you
10
are
minutes would be great.
Yeah, if you are two EMTs and you recognize shock and you know that I need to get them to a center or this patient needs blood products, then I need to weigh my options. How quickly can I get the aircraft to me, right? Or how quickly can I get the patient to blood? So either the blood's flying to me or I'm getting them to the blood. What time do I control? I control my scene time. So if I can acknowledge those findings at a rapid rate and then load and go, I'm a big proponent of that. That's the way I teach. Either you're going to bring definitive care to the patient or you're going to take the patient to definitive care. It's very easy to figure out. But we can control that. But if you're going to sit there on scene for 25 minutes and then be like, well, I got a 35-minute ride, I just ate up most of that hour now by bogging it down and just sitting there while I'm waiting on some other resource. So if you need a medic, you could do a medic intercept. If you need the flight, how long is the flight to me versus how long is my ride to Portage or Geauga or wherever we're at geographically, all those things should come into play to your decisions. But I think your point, Caleb, a lot of the basic interventions are overlooked. Sometimes as paramedics we get, well, I can give this drug and I can do this and I can do all these things, but realistically it's like, did we fall back on a lot of the basic assessment skills to make sure, did I control the bleeding, is my tourniquet appropriate, those other things that we can build on. Am I using the proper tools? No different. Did I pick the right drip set? Did I start the right IV? It's just all of those functions.
And
build
remember
up
that
to,
we have something called Ohio trauma triage. It says you shall, not should. That's law.
Yeah, it's illegal.
And literally tonight was the start of trauma for the medic class, and part of the discussions was, when does the trauma actually start? And I like to say it starts at the beginning of my shift, not at the beginning of the call. And one of the examples I gave was tomorrow, the first thing I'll do at shift change is look at the weather. And this is airing in December, and it's going, well, this is live, and we're supposed to get 8 inches of snow tomorrow. Where's my closest trauma center? It's probably not going to be a flight, because nobody's going to fly.
Nobody's going to rotor it.
It's going to have to be Geauga, and it's going to have to be planned out, and it's probably going to be a slow response, so we need to think about that tomorrow. And like I said, keep your ambulance warm. If they're outside and it's an MVA, and we're probably going to be sweating because we're cutting and everything else, and then we get in the back of the squad, let's say it's 65 degrees because that's where we keep the bay. Is the patient comfortable there when I get them stripped down? Probably not. So there's so much more to going back to the basics.
Trauma's lethal triad.
Yeah, I was making notes about the lethal triad, and really, you're just teeing this up.
I'm trying. We talked.
We rehearsed this for hours before this program to get this spot on for you. But no, I really wanted to talk about the trauma lethal triad.
And that's not talked about enough, to be honest with you. So
you were just talking about the hypothermia, right? Yes. And let's just say you are a BLS squad, and that is the only thing you can do, right? You can apply oxygen, you can keep them warm, right? Well, by keeping them warm actually helps prevent the acidosis and the coagulopathy that's going to kill them, right? How many times, let's not take a poll on the air, right? But how many times have we seen a very competent ALS crew come in, bunch of IVs in a trauma patient, right? All the holes plugged.
And the patient has a sheet on them.
And they have a sheet on them, right? Because it's the middle of summer or whatever the case may be.
And now that patient is getting whatever temperature the saline was at. And
yeah, we're making them saline temperature, which is, even at room temperature, is 10, 15 degrees less, cooler than core temperature, right? We are promoting that, as well as, if we're not judicious with our fluid drip rates, and we're also diluting, hemodiluting them at the same time.
Causing
but
a lot
that
of this.
simple thing, right? Are you cranking up the heat? Are you packaging them up and, keeping them warm? All the ALS stuff's cool.
But it goes out the window if we break the chain.
It's the BLS stuff that saves them, right?
So I would, to any crew out there, BLS or ALS, pay attention next time you bring a trauma in, because it's going to be A, B, C, D, E, and that's exposure. We get them naked, and then we cover them up.
Real quick.
Yes.
We get warm blankets out, and we cover them up, and we try to keep them as warm as possible. We need to see everything, and I tell my medics this and basics this, that if you don't know what you should have done next, stick around, and what they do in the next few minutes is probably what you should have considered.
What you should have considered. Yeah, I like that.
In the back, because that's what we're just continuing your care. Now, if you didn't have time, that's one thing. But if you ran out of things to do, and what do you think? What was the next step in care? Stick around and find out. Ask questions. Hey, why did you do that? Oh, well, we got the lethal triad. We want to keep them warm. Yeah, we're going to pack them with warm blankets. We're going to take them to the CT scanner, or we're going to throw a bear hugger on them, or we're going to run them through warm. We're going to warm our fluids and give them warm fluids. So stick around and pay attention.
Yeah, I like that. I like that. It's if you don't know if you forgot something, wait around and see what we do, because that's what you forgot.
Well,
watch the ER physician or the trauma surgeon that's going to show up, that's going to go through their ATLS assessment. And then, to your point, and keeping them warm, think outside the box in our ambulance. So turn the heat up. We have hot packs, right? I'm not saying put the hot pack directly on their skin, but if you're going to layer multiple blankets, there's nothing wrong. I've actually watched my guys do it with a septic patient coming out of the nursing home. There's I think we carry 6 hot packs, and it's a blanket, 6 hot packs, another blanket, and all we're trying to do is keep them warm for that duration. And I think sometimes it's low-hanging fruit, but it's severely overlooked. To Caleb's point, on that 98-degree day when you wreck your car and we cut you out of it and we're wearing all of our turnout gear, what's on in the back of the ambulance?
We crank the air.
We crank the air.
Right, we're
And then,
bacon.
per the Board of Pharmacy, to your point, the room temperature is defined as 68 to 72 degrees versus your body temperature now.
Right.
So, yeah, we are cooling you down. So think outside the box. We don't have a bear hugger, but I'm very pro using hot packs to try to make it our own bear hugger as best you can in between the blankets. Do not apply them directly to their skin, but have a layer. You can get into that with different hypothermia lecture, but no, I just think all those low-hanging fruit items are very easily accomplished, whether you're a BLS squad or an ALS squad, and they're just overlooked.
And don't get tunnel vision. It's very easy to fall in that hole of, oh, it's this. Oh, it's this. There's distracting injuries, especially with the extremities. And if you got a bleeder, a tourniquet's going to be what you need. Then move on. Look for what else is there, especially if if there's a mechanism of injury there that suggests more than just that distracting injury.
And now we enter our other subplot of this entire series is the story tells all, right?
The story tells all.
That's just going to be scrolling back here. We're just going to get a big monitor, right? Call med control, the story tell. What's our third subplot? There's something we always keep going back to as well. But we may as well just have it.
basic skills.
I thought that was an applause. At first it was your eyes.
It was an applause. It was our website's our third plug. Sorry.
Right, yeah. Our third routine
But
plug.
we've done a few now, right? Podcasts, and we always come back to usually the same points. The story tells all. Call med direction. I mean, it all kind of like it's like there's a thing.
It goes back to
There's a lot of theme, right?
it goes back to Varsity Blues. Stick to the basics, right?
Yeah.
Stick to the basics. No different in fire, right? And we need to aggressively occupy the interior space to search for people and put the fire out. And water's worked well for years. So why is it so complicating on this side of it?
What does Chief Norman says put the fire out, everything else gets better, right?
Yeah, and then to your point too, think outside the box a little bit. So, your GI bleeds. One of the things that I wanted to talk about was the TXA usage, and
perfect.
Being able to call medical control and say, hey, I have this GI bleed patient. I've given some fluid resuscitation. I have bright red blood. I would like to go ahead and utilize TXA, 2 grams. Whether you're going to push, drip, whatever, it doesn't matter. But take the initiative to start laying that groundwork. And to your point, when you arrive at the facility with that patient and you're going to see either the trauma surgeon or the ER physician start their trauma assessment, they're doing a lot of the same things that you're doing. They're going to go A, B, C, D, E.
TXA is very underutilized, I think. I mean, Abaxtaxis, you get a nosebleed. It's in our protocol. Use TXA. Saturate it. It's amazing. Works.
I saw a short about this recently. Has anybody seen a short? Hey, as a matter of fact, you said the exact same thing.
Watching yourself on TikTok.
I don't have social media.
You're doing a live smart man. But the TXA, just a quick recap of the history on the TXA. Like 4 years ago when we put it in, it was strictly for obvious external bleeding.
Correct. It was one dose.
with shock,
Yeah.
right? And we're doing half the dose because
Yeah,
we
we're
were
doing
doing
1
dose in the field, gram in the field, and then we.
Well, that's, to be fair, that's what standard was.
Absolutely.
Correct.
Oh, absolutely.
It's changed this year.
Yeah, no, it's morphed, and I'm kind of talking about that. I'm kind of talking about that, that morph over the last 4 years, right? The second iteration of that was, well, we've got this guy. His leg is, he's clearly got a femur fracture because he flew, off of his motorcycle, and his leg is getting. But it's not bleeding externally, even though we're putting tourniquets on it because we know it's bleeding internally. Can that patient get TXA? Well, yeah, of course that. So then that next iteration was, or obvious signs of internal bleeding, right? And then the third iteration of that kind of came with the push, right? So we're like, well, two things happened simultaneously there. One was, John and his staff on the hospital side keeps forgetting to give the other gram when we get there, the trauma guys. So they were like, push it off on EMS. No, just kidding. There was substantial data, right?
We were bad at it.
To say, give that earlier, and EMS has, again, we've talked about this one-on-one patient care opportunity that doesn't exist in the hospital, right? Utilize that. So then we ask you to get the 2 grams, and you talked a little bit about the push versus the drip, but now we're doing all 2 grams pre-hospitally. The kind of the fourth iteration there is, as you're talking about, is its topical use, right? So for this last year, it was for epistaxis. We're going to include, I figured a few more things we're going to get pushed through for 24, but the only thing, not skin, again, you could simply call.
I could call.
Oh, it absolutely will work, right?
Give it a try.
Give it a try.
Yeah, what's it going to hurt?
Throw some dirt in it.
A bleeding tooth socket if you had somebody with a bunch of teeth out.
We do that all the time.
All the time, right? Yeah. So again, same thing. Like you were so eloquently speaking on your Facebook short you've never seen. Just soak a gauze product in TXA, and fold that up, pack that up, pack the tooth hole, pack the tooth hole with that, or whatever the bleeding nair is. So I suspect we'll probably see some liberalization in the future of its topical use, right?
Well, and when we've talked about TXA in the past, right, we know the one thing it doesn't do is just send clots on down the line, right? It's actually a very safe drug.
No kidding.
Yeah.
Huh. No, that's clever. I didn't know that. Yeah,
Not just dripping clots out of
It's
it.
not just dripping clots.
my absolute pet peeve, right? And hopefully everybody out there gets the sarcasm. This is a drug that doesn't make clots because we've said it before, but
It stabilizes clots, doesn't make clots.
It doesn't make clots, right? It keeps the body from naturally breaking them down. If I gave you a drug that made clots, you would die instantaneously from a PE, a MI, and a stroke all at the same time. So let's not do that.
That's true today.
Yeah, that's not. We have. That isn't really bad.
That's not really bad.
So years ago, we used to carry for epistaxis thrombin. A topical thrombin in the drug box, and it was in a vial, and we were terrified that somebody, and that was part of the reason we got pulled, right? Is just the
Comfortability.
It's just like you have one mess up there, then you literally did what we just talked about, right?
Yep.
And you just turn blood into sludge, and you're you're going to do some serious damage to that patient. I don't know if they're tanker truck full of heparin, maybe. What's
Next on Dirty Jobs.
right? That was gonna make a mess, and that's part of the reason why it just wasn't getting used a lot the same. We talked a little bit earlier about the use of epinephrine rather than having this engineered solution like dopamine or using stuff that we already have. Epi is a shotgun of vasopressors, right? Yep. It can give us alpha response to close vessels down and increase blood pressure if we need it. Does it do that optimally as compared to your levos? Does it do it quite as well as the phenylephrine?
No, but Levofed's still our go-to pressor, and right behind that, I give Epi.
As Epi, right? So it's still good. It might not be the greatest thing in that alpha space, but it's still pretty damn good. And we also have that beta effect. So you get that patient that's bradycardic, refractory, maybe not a candidate for pacing, or they failed pacing. You can use it for whichever. You get both effects. I wish you could just tell it what to do. Like, I want beta today, go. I want alpha today, go. That'd be pretty damn cool. But we have one agent that does multiple things. That is, we were talking about this a little bit on a phone call the other night. That is a lot of your medications in your drug box for EMS. Is we get the most bang for your buck. At the end of the day, we try to mirror emergency medicine, but we're carrying it all on our back, right? Yeah. So you have to be wise in your, let's take ketamine, for example, right? Here's a drug with multiple indications, and you can use it for multiple things. Let's talk about amiodarone, right? Yeah, it's officially listed as a potassium channel blocker, but it has sodium channel blocking, beta blocking, and calcium channel blocking properties as part of it. We have a lot of examples in our drug box of, multi-talented drugs, right? Yeah. They can do a couple of things. They can do them generally well. The message here being, if we use these things in the field and you switch to a different pressor when you get to the hospital, you haven't shorted the patient, right?
No, not at all.
You haven't shorted the dosing might be different. That you might have to use a little less or a little more. That doesn't mean you were doing anything wrong, right? But when you really zoom out and you start looking at some of our choices on what goes into the protocol, right? There's reasons behind that. We want to get the most out of it.
Well, and looking at Epi too, we use Epi IM and intramuscularly. We use it intravascularly. We can, although not in the protocol, give it via ET tube. But there's multiple ways to use the medication. Yep.
Inhalation, absolutely.
So yeah, it's multiple different. But it's like, to your point, it's a go-to like for a lot of things. So why not cut down? I mean, I hate seeing things like this disappearing from the protocol.
That bothers me.
Because I am a fan of tool in the toolboxes. When I want a particular tool, I like the one that fits that need the most. That's why I keep Ray around.
Not the sharpest tool in the shed.
The TXA point I forgot to make.
Yes, I'm trying to go off your notes, but I keep on
These
mine.
are my notes.
All right, I go off.
We always got to read Scott's notes.
Why are you reading my notes? And why am I
Caleb
taking?
and I take zero
The problem
credit for
is,
them.
if anybody
This is
can
how
see
they
that,
got through school. Is
Scott's
reading.
notes. It's like looking at the cave that Jesus might have been in.
That is advanced doctor handwriting, right? You could write it so sloppy nobody else can.
I think that says handicap.
Oh, no, ruined my handwriting.
But the TXA point that you started to make, I was talking about the evolution and then forgot to actually get back to, was its use in non-traumatic bleeding, right? And your example was what looks, smells, talks, walks like a GI bleed, right? And you got this, hypotensive patient. Can we or should we consider that? And that last evolution, last year, we put in not the traumatic protocols, but in the non-traumatic shock, there's a red box, right? And I don't want people to get confused. And that red box means you have to call them for medical control authorization. For all your traumatic bleeding or obvious bleeding, right? Again, he's shot in the leg and his leg's this big. What's in there? It's all of his circulating volume, right? Yeah. Tourniquet that, and then you can go ahead and give your TXA.
Yeah, it's blue box.
It's absolutely blue box, right? Or if that's if that same amount is spilled out on the on the floor next to, absolutely give your TXA. But in your case, with a medically potentiated case, right? We have now given the option. We still at this point want you to make a phone call for the TXA and pros, cons. Is this really something we need to do right now? Is this something we want some more imagery, diagnostic procedures on? But again, that can be weighed out with the physician real time.
And I think that the reason why we're hesitant on that is because in the studies it hasn't shown to bear out to be any benefit. Do I still do it if they're sick? Yep, absolutely. Sure. Why not? Because if it's going to work on that patient, I only care about that one patient at that time. I don't care if it worked 50% of the time. Well, if I roll the dice and I nailed it this time, yeah, we're all good. I saved a life, right? For it.
Yeah.
I'll use your terminology for a drug that has exquisitely low risk of harm. All right.
Now, there are some hemorrhages we'd probably want to stay away from.
Such as?
Well, I was kind of leading in for that for you guys.
No, you have to finish the thought.
Strokes. Like, I'm not going to want to give this for somebody with a hemorrhagic stroke or suspicion of one or CVA. So, I mean, there are hemorrhages that I wouldn't throw it at, but it's few and far between. I mean, like you said, it's pretty safe.
It's a very safe drug. Yeah. And in fact, other specialties have been using it a lot longer and more, a lot more than we have. OB and gynecology uses it a lot in their everyday care of their patients.
Yeah.
Abnormal uterine bleeding, we've tried all the things. Next step's going to be oral TXA.
I was about to say, there's take-home TXA as a tablet, right?
And then, Ray, I'll set you up for your favorite word. The reason we wouldn't want to give it in their stroke is because we're trying to save the
penumbra.
Yeah, there you go.
There, we just had to sneak that in.
So if I can redirect us a little bit, we talked a lot about hemorrhagic stroke.
Let's talk about the different other kinds.
Oh,
Yeah.
we talking about
There's other
strokes?
kinds.
We're not talking about stroke yet, are we?
Shocks. The other S word.
The other S. Shock, stroke.
Yeah,
It's medicines.
Yeah.
It's just doctor words.
I was waiting.
Obstructive.
Can I talk a lose for obstructive shock?
Sure.
So, Dr. Spanner led us down this path of the obstructive. I almost said obstructive stroke.
I would argue all strokes are pretty much obstructive.
Pretty much obstructive. Yeah. True. Obstructive shock. And we talked a lot about, of course, tension pneumothorax and recognizing that. And we distilled down just some, and then of course, follow-up for that for the pre-hospital provider, the advanced EMT and the paramedic, of course, darting the chest, doing a needle thoracostomy. Talked all that in the previous segments, but one of the things, again, I opened with some lose stuff with the hemorrhagic patient. Let's say we have a patient that has pericardial tamponade, right? What can I do in the field? Not a lot.
Not much anymore.
I can identify it, right? And I can properly triage the patient. Huge in and of itself.
I would appreciate a phone call to that effect.
Doc, I have JVD, muffled heart sounds. Just
I've positive
lay
facts
it out.
triad.
Yeah.
I'm inbound to you.
Yeah,
Right?
yes.
If I said that on the phone, they get your attention.
It would get my attention. It would make me have certain things available as soon as we arrive so I can fix it.
Yes.
I hate
Or try to
saying
fix
this again, but this comes back to good field. What is it? And let me bring you my diagnosis and let you carry on the baton. But without a good history, you might not meet that patient. They might have crashed already.
Yeah.
So
Working them as a PEA arrest or something, which is kind of where I was going, is preventing that PEA arrest. So let's say we have that patient with all of Beck's triad, right?
Yeah.
This is just textbook. It's being served up on a platter for me. The story's there, right? And I volume resuscitate because their blood pressure's crap, and
Doesn't do anything.
nothing happens, right?
start thinking.
So yeah, and the point I wanted to make is you have to do something, right? You can't let them just stay in shock and die. And although our initial treatment for these patients is volume resuscitation, they're not volume down. That's not their pump is compromised. So what do you have anything to make pump squeeze a little harder? Do you have anything that can crank up? You do. Of course, that's where back to our vasopressors, our push dose epinephrine. Again, I'm not suggesting that you run out and start immediately pressing these patients. Try the easy stuff first, right?
Yeah.
But there are these situations that are definitely kind of lose, and the patient still may not do well, right?
I had 2 cases very recently where everyone did exactly what they should do in an exact amount of time frame, and it just didn't work out.
Didn't work, right?
I had 2 cases, 2 cardiac arrests, young people just recently. I mean, response times were sub 2 minutes with bystander CPR, like Rosk in the field, checked all the things, and they still didn't make it.
Right. But
And just sometimes it's not in the cards.
It's
You
not in
do
the cards.
everything right, and the outcome is still garbage.
yep. But in this particular lose-lose situation, we can't leave them hypotensive, right? Or we have to try. And action is always defendable, right?
Correct.
And end of the day,
No, what providing
let's-
facility doesn't do pericardial synthesis, though? I mean, that's as long as we get them to where they need to be.
If you get them to an ER doctor, we'll do it. We're not gonna be happy about it, but we'll do it.
right.
But I mean, it's, again, if we can recognize that it exists, I see Beck's triad. I give you a good phone call. I have people waiting or ready. I get them to the right place. Again, field diagnosis.
Even in your house, that early notification may be the difference between you doing it in a crisis and you calling down the pro that that
Goop that shows up.
right.
I've seen him do it in person.
Hopping in the back of the truck and be like, nah, just splash the betadine and go to work, right?
I brought the ultrasound with me.
Yeah.
60 cc syringe.
Believe it or not, when I started in paramedics, I know you and you.
Yep.
Yes.
It was in the protocol.
It was.
Yeah,
for
it was.
paramedics.
It was. Yeah.
Shove this needle in and aspirate.
Go to a clicks.
But I think you're building your point on some of these situations are lose-lose. We have versatile tools in the drug box. We need to know how to utilize them. And you're essentially just trying to buy time for that patient that's in shock because the heart is obstructed from working. We ideally know they need pericardial synthesis, which I know in Chicago Fire they do it and it's cool, but in the real world we don't, pre-hospitally. So we got to get them to you, and hopefully we have enough time to do that.
There are pockets of the world where that is still pre-hospital.
If at one point our protocol allowed it, obviously we knew how to diagnose it semi.
Yeah.
So why can't we still do that? We can.
Those arcs are those arcs of change are happening at the state right now, right? If the medical control
I am in the
feels
middle
it's
of trying
appropriate.
to find ultrasonic arms for our doctors in the ERs because they want to start training on this if it should come this way, but they're already doing it in the ERs. So we are shifting to some cool areas.
One of the things that Dr. Spanner, I think, did a really nice job of is talking about pulse pressures in that segment. About essentially kind of distilling it down, like narrow pulse pressures are hemorrhagic or generally hemorrhagic or obstructive in nature, and then the widening is usually
Hemorrhagic or
is
Distributive?
thank you.
there. Oh, that's what you're going for.
Thank you.
A pipe problem.
Yeah. We vasodilated, right? The distributor shock problem, and that is kind of helpful to kind of differentiate between the two. One of the things that I don't think gets enough airtime is a shock index. So I know it's probably used a little bit more in the house than it is out of the house, i.e., in the hospital than it is outside. But
Funny story. I think 2 years ago, you and I had a conversation about shock index, and it was like, man, Scott, I heard this. What do you think about this? And we started talking about it, and it's just I don't think I've heard anything about it since then.
it was probably as a result of a publication or something like that.
Yeah, I think it was.
But what I don't even know if you know, but as a result of that conversation, so I think there's some. So first of all, the shock index is heart rate divided by systolic blood pressure, right?
Real hard math.
It's some of the most
And it was
difficult.
amazing to me, though, how many times out of not you found out a patient probably needed
Yes.
fluid. And it was like, oh.
And then, if that the result of that is 0.9 or greater, then they're in shock, right?
And an indication for us to get blood products.
And you're an indication to get blood products, yeah. So, one of the things that my initial response to our early discussions were like, hey, this probably has some utility, but are we really going to take the time to do the math? And of course, the answer to that's no. So my first stop was to go to our EPCR vendor and say, and the ticket is still in. They've not taken action on this.
Based on our vitals, can't you just produce this?
I'm like, you. If I put these two numbers in, just
Yes.
Right? It's an if, that's simple math, and then an if-then statement. If it's greater than this or less, then just give me a
spits it out.
little
Says, hey.
flag that says, "Hey, this is shock." Right? So
Yeah.
I've asked for them to do that, also to identify widening or narrowing pulse pressures, like wide pulse pressure, narrow pulse pressure. Right? So even if you get you get a blood pressure with two numbers, both which are independently good, right? But the space between them is no good, right? And you miss that, you miss that space. It was going to pop out in the EPCR, right? I've asked for that. I should have followed up on where that ticket was before I came and sat down here and started talking about it. But of course, I didn't do that.
They haven't gotten back to you yet.
They still haven't got back to me yet. But that request has gone in. And then furthermore, last year I was lucky enough to go give some input on some new monitoring devices that are being worked on by one of our major cardiac monitor people. And one of my things, like, it's great. Yeah, I didn't realize that the obvious miss here was you're going to import all of your data after the call, and this would be like, oh, my patient was in shock. Oops, right? You didn't do it, unless you're putting it in real time. Yes. You need it. So where does it have to start? It has to come out of the machine, right? And again, that math is simple. I asked them, and I had a bunch of asks for them as they're thinking about what the next generation of devices look like. And one of those things was, hey. The shock
just another alarm, right?
Right.
Yeah.
The shock
apnea alarm. I've got a hypoxic alarm.
Correct. Blood pressure comes back and gives you, probable shock alarm or something to that effect, right? The math is easy. It's well established. This, it's not like we're on doing fringe medicine here, right? And so, like you said, it's a well set. That's your trigger for somebody who's likely to need blood, right? Yep. Not news. But
I can't wait for the day. Hey, squad, give a liter of blood. Okay. That's my Siri squad.
We need to figure out how to synthesize that blood. Is really what it comes down to, because we're just not going to have enough donors to.
That's a serious problem.
Yeah,
for all the blood banks currently right now, and yeah,
has been not news.
Yeah,
not news. Right.
Has been.
All right. Well, hey, you guys got anything else about
questions from the audience? Maybe. Sorry, John.
There's nothing there.
John.
They're all hunkered down because of Snowmageddon. Nobody wants to. Nobody wants to talk to us today.
You want to plug our web.
You hurt my last feeling.
Shut up, Scott.
No. Plug something, John. No, I know what he wants to plug, and this is good stuff.
I do want to plug our website. If you guys haven't gone to our website, prehospitalparadigm.com, there's a lot of stuff on there. Obviously, all the podcast episodes, the med directors, we got tech medicine up there. We've got equipment information. We've got medication information, but also something we're developing over this past year has been great cases. And I know Spanner talked about a case that he had in which we talk about these patients that are in anaphylactic shock that die from lack of epinephrine. One of my crews in Sebring, I'll give them a shout out, had a fantastic case where a guy was circling the drain.
This was great,
and got multiple doses of epinephrine and saved his life.
Yep.
Not only saved his life, but the last time this happened, he was intubated in the ICU for multiple days. Yeah. They arrived this patient at the hospital with a systolic blood pressure like 110 or something.
Nice.
So they did everything right, and they slammed this guy with epinephrine and kept him alive. Yeah, he stayed the night in the ICU because he almost died that day.
Sure.
But one stay in the ICU, oh, you're better, you're fine. I can discharge you home after a day or two. That's a much better stay than 5 days intubated.
That's a clutch,
That's
yeah.
awesome.
Yeah. It's a clutch call.
It's a great case. Go review it.
And that was both IM and IV epi, right? And that was really that what saved him is that transition to the IV.
And I guess obviously there's takeaways there from understanding how epi works, when to use it. But I think the bigger takeaway from just epinephrine is like if you have a sick patient and they are doing, I don't want to say weird things, but they're actively trying to die on you, you have to meet that same type of effort that they're trying to die on you.
Yeah.
So you need to reach deep into your bag and you need to just pull the trigger and do the things. And in this case, it was epinephrine.
Match their death effort.
Yeah.
I need to write. Thankfully, that's memorized. That's brilliant. Yeah, we're gonna do a whole series on that. But
You got to work more. You have to work harder than what they're trying to die.
yeah, no, that's good note there. That's just happens to be one of the
that's one
last.
case.
Yeah, right. And generally easy reads.
Yeah.
We're talking what 4 or 5 paragraph
Yep.
cases. So you're not like reading all about this patient who likes long walks on the beach and what their what their sign is and all that.
Short, sweet, to the
yeah,
point.
straight, and what went well and what went wrong, and what EMS needs to focus on and what we can. It's really tuned for us. It's not. Dr. Spann or Dr. Singer do a really nice job of tuning it for this audience. So if you're not checking out the great cases on prehospitalparadigm.com,
And I believe there's also CE available for the great cases as well. Is that correct?
I don't believe not yet.
Oh, sorry.
We're getting there.
Work in progress.
We're working on a lot of CE options for you for these podcasts, but it is proving to be a difficult adventure.
It's an easy adventure if we just want to do Ohio, but I
Yeah.
think we want to be more broad than just Ohio.
Absolutely.
Looking at statistics, this is a little peek behind the curtain. I want to say 75-80% are United States. Outside of Ohio, Texas, California are pretty big.
Yep.
But even internationally, we get South Africa.
South Africa, there was Germany, there's been Australia.
Yep.
So, hey, we didn't even know we were relevant in Ohio, let alone on another country, mate. You're absolutely right. So,
You want to talk about the survey, the email that came out a little bit? For people to respond to that, if they subscribe, they can give some feedback as to...
I'm glad you remembered that because I've forgotten all about that. But we look in your inbox for the voluminous amount of email that
plethora.
we're working on it, right? We're trying to shrink some of that down, make that a little more less frequent, but with more quality, right? So it's something that's on our minds, and although that's not exactly our purview on this side of the table, it's something we're working with that team to shrink that down. One of those things, you're absolutely right. I'm glad you said that. Our marketing people will be happy that you remembered that. That survey went out, and we really need, we want to know how to tune this product for you. We can do this, sit here and do this the way we want to do it all day long, and be relevant to ourselves. But we need it to be relevant to you all. So it's on our website as well as in that email. There's a link to it, so you can either search your email or just hop on prehospitalparadigm.com. and check that out. We'd be grateful for that feedback. Short survey. Nothing fancy, but just help steer us in the right direction. With that being said, you've plugged your things. You remember to plug your things. Any Palmadine things?
I was just going to say
any Palmadine.
If Palmadine's listening, I'm looking for.
So, well, hey, we appreciate you guys tuning in. This
This is Pre-Hospital Palmadine Podcast.
it's just Caleb sitting there with all their product offerings.
I do wear an XL.
I'll just say next month is Q&A.
Yep.
So already in the can recorded. Those will come out the first 3 Mondays as usual. And it's all right with you guys. I think we're going to take Christmas off this year.
I think we ought to. Yeah.
So the next time we'll be live will be in January.
So we'll see you.
Happy holidays, Merry Christmas.
Yeah, we'll see you in January. Thanks all. Have a good night.
Pre-Hospital Palmadine.